Hello, this is Dr. Holtzman from the Karolinska University Hospital in Stockholm, Sweden. I will say a few words about a study that we recently published. It's on the association between treatment for erectile dysfunction and cardiovascular outcomes and survival after a first myocardial infarction in men. Erectile dysfunction is common and is thought to affect 20 to 40% among men between 60 and 70 years of age. A number of studies have found that erectile dysfunction is related to an increased risk of cardiovascular disease and mortality, both in previously healthy men as well as in men with high risk for cardiovascular disease. There are no studies on erectile dysfunction outcomes after myocardial infarction. We hypothesized that erectile dysfunction is associated with an increased risk of death and cardiovascular outcomes in men after first myocardial infarction. We had no information about erectile dysfunction from questionnaires or other sources, so we used medication for erectile dysfunction as a proxy for the exposure, meaning that what we really studied was medication rather than erectile dysfunction in itself. Essentially, there are two types of ED medication, the so-called PDE5 inhibitors, which are used orally, and alprostadil, which is prostaglandin E1, which is used locally. Sildenafil was originally developed as a cardiovascular drug, mainly to be used for angina. However, due to the short half-life, it was not practical to use, but a side effect found was that erectile function improved. Sildenafil was registered as Viagra 1998 and was followed by tadalafil and vardenafil 2003. I will say a few words about the data sources that we use. One of the wonderful things with Sweden is that we have a number of registers, and these registers have a complete coverage of the country. One of those registers is the patient register, where all hospital stays are registered with a complete coverage since 1987. So the study population came from the patient register, and we added information from the prescribed drug register about ED medication. For outcome, we use the patient register. For hospital stays and for deaths, we use the cause of death register. The study population consisted of all 43,145 men with the first myocardial infarction in Sweden during 2007 until 2013. Only 7% of men had any ED medication dispensed during follow-up. Men with treatment for ED were slightly younger, less likely to have diabetes and prior stroke, but had similar prevalence of heart failure. Cardiovascular use was more common among men who did not receive ED medication. In total, there were 4,853 deaths during a mean follow-up of 3.3 years. The risk of death was reduced by 33% in men who were treated for ED compared to men without treatment after adjustment for confounders. In total, there were 2,444 patients who were hospitalized for heart failure during follow-up, 6% in men without treatment versus 1.4% in men with treatment for ED. The risk of heart failure was reduced by 40% in men who were treated for ED compared to those who were not treated for ED. There were some limitations in our study, namely we did not have information on physical activity, nor did we have information about household disposable income, nor did we know if the men were married or not, and all these things may be related to both ED medication, but also more importantly with survival after myocardial infarction. Only PDE5 inhibitors were associated with a reduced risk of death and heart failure, but not alprostadil. The risk reduction associated with treatment with PDE5 inhibitors appeared to be dose-dependent, with an 81% reduction in mortality among men with more than 5 dispensed prescriptions. So to summarize our findings, we found that the men with the first myocardial infarction who were treated with ED medication had a markedly lower risk of mortality and hospitalization for heart failure during a mean follow-up years. This risk reduction was only seen for men treated with PDE5 inhibitors. and the risk appeared to be dose dependent. Also, I'd like to thank my team, Daniel, who came up with the idea and drafted the manuscript with me, and Alessandra and Reno, who did the statistical work, Michael, who was the andrologist among us, and finally Ylva, who actually brought us all together. Thank you.